The last speaker for this part of the session will be Vas Sada. He'll be speaking on anatomic predictors of visual outcomes after long-term anti-VEGF therapy. Vas?
Yeah, thanks very much. I'm going to continue the theme sort of for this session. So these are my relevant disclosures. And so again, I think we've all been very interested in what anatomic predictors may exist in terms of our patients being treated for neovascular AMD. We've actually been interested in that question dating back to the time domain OCT era, and we'd actually first described that this SHREM or subretinal hyperreflective material, we called it something different at that time, but that seemed to be a very important predictor in terms of patients' vision, and it kind of is common sense. If you have stuff between your photoreceptors and RPE, that's probably bad. And this, of course, was replicated by the CAT investigators and Glenn Jaffe, and they certainly found, again, the same association between SHREM or fibrosis, but also that atrophy and intraretinal fluid appeared to be associated with worse vision. The interesting thing was that they also observed that there appeared to be better vision in eyes that had subretinal fluid, but also sub-RPE fluid. And I'm going to focus in on PEDs a bit in this presentation. Now, of course, the CAT the extension went to 5 years, and so far, if we want to look at data beyond 5 years, that data is somewhat limited. We have some information from the 7UP trial. That, as most of you know, is a pretty small subset of the original patients enrolled in Marine and Anchor, and we had reported that there was this huge number of patients who developed atrophy. Nearly all of them had by the end of the study. I just want to provide one caveat that remember that in this study, atrophy was assessed on fundus autofluorescence. So actually, this atrophy was a mixture of what we would all consider as atrophy, as well as the SHREM or fibrosis. Most of it was atrophy, as it turns out. But still, it's this combination. Again, atrophy and this SHREM appeared to be associated with worse vision. Now, unfortunately, in this study, we didn't really focus in on PEDs and sub-RPE fluid. And you heard earlier from Bailey, and also David mentioned this in his presentation. This was a nice collaborative project with Bailey Freund and David Saraf, where we looked at patients long-term, again, who had type 1 neovascular membranes, and when you look to see, who was developing atrophy, where was the atrophy developing, it seemed the atrophy was developing sort of at the margins of the PED, not at the apex of the PED. So again, Bailey showed some beautiful cases, I thought, but this is just an example of a patient from my practice as well, who obviously has type 1 neovascularization, treated with anti-VEGF therapy, and 7 years later, actually, you can see that she actually ended up with very good vision, 20/25. Interestingly, the phenotype or the morphology in this treated eye looks very similar to her fellow eye that we never treated, but has this type of non-exudative neovascular AMD, and based on information that Bailey and others are presenting, you wonder, is this patient cured? And really, I guess what I'm getting at is, I think in this current era, we're all iterating towards what is our actual optimal endpoint that we're trying to achieve for our patients, because we are interested in their long-term outcomes, because most of them don't live just for the duration of the trial. And so that being the case, we ask the question, well, if we're trying to titrate to some optimal endpoint, does the thickness of the pigment attachment have an impact? And so we undertook this study. It is a retrospective study, but a collaboration between David and myself at UCLA, but also Ghazala O'Keefe at Emory, and Charlie Wyckoff and Dave Brown at Houston. And we identified 204 eyes of 177 patients who had been treated for at least 5 years. You'll see most of them were treated quite a bit longer with anti-VEGF therapy for their neovascular AMD. And we divided them into 3 groups for the purpose of analysis, into sort of a poor vision group, worse than 2200 legal blindness, intermediate vision, which is self-explanatory, and good vision, better than 20/40. We also looked at this question that Rick raised with regards to number of injections. And we looked at the OCT data. We analyzed it for the thickness of these things that we were interested in, the PED, the SHREM, the subretinal fluid. We also looked at the choroidal thickness, because there's some information that patients with a thinner choroid tend to have subretinal drusenoid deposits. They may be more prone to atrophy. But of course, we also looked at the status of the outer retinal bands, because you'd think logically those would be the most important in terms of vision correlation. So what did we observe? Again, just to highlight that these patients were on average followed almost 8 years. These investigators all, I think, recognized the importance of therapy and treating patients regularly that Rick highlighted. So even at 8 years, they were averaging over 5 injections a year. Again, it's obviously not linear. They received more in the earlier years, but over 40 injections were received by this group, so I don't think they were undertreated. But in any event, what did we observe? Again, we observed the relationship that Rick has pointed out, even in this long term. Patients who had poor vision tended to have fewer injections, but the interaction may be more complex because patients who had good vision also had fewer injections. And maybe if you follow these patients long enough, there are some subset of patients who seem to need less therapy over time. At 8 years at least, or in the average of this population, we no longer found that subretinal fluid thickness seemed to matter. But again, we confirmed that SHREM thickness really did matter. The thicker your SHREM, the more likely to have poor vision. The poorer vision group clearly has a thicker SHREM, but also, if we look at PED, the best vision was observed in patients who had a thicker PED, especially a thicker PED under the fovea. This is just illustrated graphically for the entire macula or in the fovea. Again, if you had a poor vision, you tended to have a shallower PED compared to patients with good vision, but thicker SHREM. Okay, so again, we thought that maybe Bailey talked about this concept of the neovascularization, sort of recapitulating the choroid capillaris, and so we thought maybe this would be of greater benefit in patients with a thinner choroid, and overall we did observe that combination of choroidal thickness and the PED thickness appeared to correlate with the visual outcome. So overall, our finding is that the best configurations, we think about what is the endpoint we want to achieve for a patient, was having a PED and no SHREM was better than not having a PED is the final result. Of course, the outer retinal bands were highly predictive in addition to the PED thickness. So obviously the optimal outcome is having an intact outer retina over this type of hypervascular PED. There's just a couple of cases. We just randomly picked a couple of cases, ended up with good versus bad vision. This patient was treated over 6 years, 27 injections. You can see they retained a small PED at the final visit, had a good vision outcome. This is another patient, again, now followed for many more years, and 59 injections, has a small PED still with a good vision outcome. And here's a patient had a type 3 lesion initially. Obviously, the PED collapsed. They developed atrophy, even with a very small number of injections. And here's yet another patient, again, atrophy in the end, collapse of the PED, poor vision. So to summarize, we observed that the presence and thickness of the PED under the fovea was an important predictor of how somebody did in terms of their vision long term. The best morphology, again, is absence of SHREM and a thicker PED with an intact overlying RPE. I want to emphasize this is a retrospective analysis. We obviously need to confirm this with future trials, but this, I think, does start this discussion of what is the optimal endpoint for successful anti-VEGF therapy. Finally, I want to acknowledge my fellows who worked on this project as well as our collaborators on this project. Thank you very much.